Hello students, my name is Liz Attia and today's topic is euthanasia. Okay, so euthanasia. In terms, I guess, of the origin of the term euthanasia, it means good death or dying well. Now, it's important that you take note of the fact that there are different kinds of euthanasia, and depending upon which kind of euthanasia you're talking about, so are the legal issues and the legal implications. There's voluntary euthanasia, which is the killing of a person at their request with the intention of ending that person's suffering. Non-voluntary euthanasia, which is the decision to terminate the life of a person who does not have the capacity to comprehend and so cannot provide meaningful consent. So the difference there between voluntary and non-voluntary euthanasia is the consent which is given. And then involuntary euthanasia, the decision to terminate the life of a person against their will or consent, which is essentially manslaughter. So voluntary means ending the person's life at their request. Non-voluntary means that they cannot consent, and involuntary means against their consent. Then there's also differences in euthanasia based on the process. There's active euthanasia, passive euthanasia, and physician-assisted suicide. So active euthanasia is giving a patient a treatment that directly and intentionally results in their death. So it's by action. Whereas passive euthanasia is the withdrawal of a life-saving or sustaining treatment, knowing that the omission will result in death. So often what we actually see in our Australian healthcare practice, and it's the legal type of euthanasia is passive euthanasia, where there'll be the withdrawal of life-saving or sustaining treatment, knowing that death will actually eventuate, which is quite different to active euthanasia and physician-assisted suicide, where a person, clearly a physician, provides the means or the information about the means to allow another person to actually end their life. So in Australia, passive euthanasia is the only type of euthanasia that is in fact currently legal. Now we have this situation in practice where there's the double effect, I guess, by Thomas Aquinas, who was actually a Christian philosopher who wrote in the 13th century. And he actually talked about the fact that sometimes there are circumstances where we might differentiate between an action that we know is likely to result in that would cause evil, but with the intent of causing good. So he actually says, in order to justify performing an evil act in the pursuit of good, 4 conditions must be satisfied. The action must be good in and of itself. The agent must have only intended the good effect. The evil effect cannot be a means to the good effect, and there's sufficient reason to permit the bad effect. What does this mean actually in practice for us? What are we talking about? Well, with euthanasia, we might distinguish between acting in such a way that death was intended and acting in a way that caused death as the foreseen but unintended effect in the pursuit of another goal, such as pain relief. And what I'm talking about here is often what you'll actually find in healthcare practice is the unspoken reality where in the pursuit of pain relief, particularly with dosages of morphine, health professionals and practitioners will know that they're hastening death, although the intended and articulated action is in the pursuit of pain relief. So whether or not this is ethical then becomes based on what Aquinas was talking about, quite shady in terms of that grey. You'll find it's quite a common practice, although it's unspoken about. In terms, I guess, of the support for active voluntary euthanasia, the support generally comes from a number of different arguments. The fact that it mirrors consensus within society, it's generally supported by members of the public. The fact that it's an individual's right to choose based on liberalist ideology. So individuals within a democracy should be allowed the free exercise of their choice. that it's consistent with our social, moral and legal ethical stance of modern Australia. And that really, it's about doing good, it's about relieving suffering, and it's inner desire and the pursuit for compassion. You know, the idea that we actually put animals out of suffering. Why wouldn't we do that for human beings? And people have the right to actually die with dignity. Physician-assisted suicide opens up a different kettle of fish in terms of the Hippocratic Oath, and also what physicians actually consider to be their role in that relationship. But advocates say that having physician-assisted suicide available is a comfort to patients because they know that they can end their own lives if and when they make that decision by their own action, not the doctors. And because of this, many medical professionals prefer the concept of physician-assisted suicide to active voluntary euthanasia, so providing professional assistance on how to actually end life with dignity becomes important. And it is interesting and important to highlight at this point that those advocates of physician-assisted suicide and of voluntary euthanasia will actually say that they're not necessarily proponents of euthanasia per se. It's just about the right to choose it if it's right for those particular individuals. Similar to abortion, those who actually argue in the interests of free choice will say that they're not necessarily pro-abortion, they're just pro-choice, the ability to choose for yourself as opposed to having it as a taboo and illegal action. The proponents against euthanasia will actually talk about the slippery slope, and they'll actually say that physician-assisted suicide or active voluntary euthanasia opens the floodgates where other types of action then becomes more permissible. So it increases the risk and rate of involuntary euthanasia, who then can, how can we stop situations where people don't consent when being euthanized? Because once we open those floodgates, our moral paradigm of what becomes permissible keeps shifting, and we end up in this slippery slope situation where gradually over time we become desensitized to the sanctity of life, and death becomes a viable option not only for those who choose it but for also those who can't choose it as well. Interestingly, in the Netherlands, where euthanasia is in fact legal, it was found that 0.8% of euthanasia deaths were performed without the explicit request of their patient. Most, 59%, were suffering severely and incompetent, and the decisions were made by family, and the decisions were made with medical professionals to shorten their lives, typically only by days or weeks. So it wasn't a long period of time. While this might be morally permissible, it shows abuse of the stipulations laid out. So even though it is in fact legal, and 59%, you might actually say, well, it is the majority, but what about that, 31%, 41% there? What happened and what was the situation in those particular circumstances? So it does certainly raise questions and concerns about the attempts to legislate for active voluntary euthanasia and what the effect of that would actually be for those who don't wish to die, as argued in the textbook. And it does seem likely that any legislation of euthanasia will probably be associated with a small number of cases of involuntary euthanasia as well. And that's the argument that Kerridge raises in the textbook on page 635. So I guess if we were actually to apply this in practice and we look at case in point of the elderly, a common and unspoken agenda is whether health resources from a justice perspective should be rationed for the elderly so that they could be used elsewhere where they might do more good. What would this actually mean in terms of the sanctity of life questions and euthanasia arguments more generally? So David Callahan actually has suggested that some of the goals of medicine, such as prolonging life, might no longer be appropriate when applied to the care of the elderly, and that science and medical advancement is such that really we can extend life so far that it becomes unethical to do so. And he says that there would be better ways in the future to spend our money than on indefinitely extending the life of the elderly. He goes on to suggest that society should define the natural lifespan, and that once patient reaches this age, it should no longer be obligatory to extend their life through technology. Instead, the priority of healthcare should shift to the relief of suffering only. And clearly, for obvious reasons, this idea has been the subject of great controversy. And I'm asking you this week to actually share what you think with respect to this argument by David Callaghan. I guess the arguments against would be, how do we decide what the cut-off age would be? It's an arbitrary age. What would we decide it should be? Is it 82? Is it 84? What if you're 79? This idea of the notch problem. And do we really conceive and would we really expect that elderly people would actually agree with this prioritisation of resources? What gives younger people any more valid claim to resources than somebody who's older? What kind of value statement are we actually taking and making there about the quality of life and the sanctity of that elderly person's life, as we would with any other group, vulnerable group in society, such as people who have a disability. Thank you, students. That brings today's topic to an end.